Welcome everyone to COVID-19 Provider Update number 38. I'm Dave Battinelli, Chief Medical Officer, Vice Dean at the School of Medicine. And I am joined by an illustrious crew tonight. We have Dr. Bruce Farber here with us again. Bruce is the Chief of the Division of Infectious Diseases and all things infectious disease for Northwell. And also by Dr. Mark Jarrett, who is our Deputy Chief Medical Officer and Senior Vice President and our Chief Quality Officer. And Dr. Maria Carney, who's the Chief of the Division of Geriatrics and Palliative Care Medicine, and involved obviously helping us understand how we care for our elders across the entire organization. But before we get going with what they'll be talking about, I want to sandwich in my presentation about books tonight, because these books are both quite long. The first book is The Great Influenza by John Barry. A long book, 900 pages, so it's a little tough to get through, but it was reprinted for the 100th anniversary of the pandemic of 1918 in 2018. And I have to tell you, I'm going to go through a couple of pictures. If we could have the next slide. It is a remarkable, remarkable story, and really does help us really understand what a true pandemic is. And some of these pictures are just incredible. But what's more incredible, next slide, is the parallels to what's actually going on right now. And when I say parallels, I mean every single piece of this. Next slide. It's the point where people are dying in the streets back then, dying at home. There's descriptions of people with, deaths, corpses in their homes for days to weeks, sometimes actually sleeping in the same quarters. As you can see in this picture, a young mother on her deathbed with a child at her bedside. Next slide, just look at this slide. If we look at the Morcello report, it's looked like she was putting it out in 1918. And this is not just in this area. This is New York, London, Paris, Berlin. This was really an incredible pandemic. And the next slide, the things that just didn't seem to catch on now that we lived through back in 1918 in terms of public health. I mean, just look at what this actually says. There is no medicine which will prevent it. Keep away from public meetings, theaters. Keep the mouth and nose covered. When a member of the household becomes ill, place him or her. It's the same exact thing. And this is actually at a time when we did not even know what the etiology of influenza was. It was thought by people such as Avery and Welch and Flexner that this was a bacterium. In fact, that's how Haemophilus influenza was in fact coined, because that was the bacterium that they saw in the lungs along with strep, etc. But next slide. Again, the parallels were crazy. The politics of this were nuts. People claimed that the only way you could catch this is actually by being afraid of it. There was an enormous faction that refused to wear masks because they thought it was an infraction upon their liberties. Again, next slide. Again, very, very same thing. Frontline workers all becoming sick. Doctors, nurses, medical students dying. It just shows us that the history lessons should be there for a reason, and that the politicization that we've seen of this and the incredible divide that we've seen to date could have been avoided if we learned some of the lessons back from 1918. So I tell you all to wander through it. It's not just a great description of what happened then, but it's a great description of the birth of real scientific medicine, bacteriology, etc., from about the period of just before 1900 through about 1940. So, the birth of places such as the Rockefeller Institute, Hopkins, etc. So, one of my books for today. So next slide. So we'll start with Dr. Bruce Farber giving us an update on vaccine and rapid testing update. Hopefully we'll learn a little bit more about the intricacies and the complications and how complicated it is to actually produce and distribute the vaccine. And then also, what can we expect on rapid testing update, which will have to be a critical feature of getting us through the next couple of years. Bruce?
Thank you so much, David. Next slide. So briefly, the part is that most all COVID-19 vaccines are using a completely different platform compared to any vaccine that any of us have ever gotten. And the new platforms that are entering center stage are the messenger RNA, a pure DNA, and a viral vector antigen-presenting cell platform that allows for the fast production of these vaccines. Millions can produce very quickly, unlike, say, influenza viral vaccine that requires eggs to grow the virus. With the exception, though, of the dog rabies vaccine and a human Ebola vaccine, there has not been any human experience with any of these platforms to date. And until large numbers of people have been vaccinated, the true toxicity of any vaccine will not be known. Next slide. So what about this coronavirus? This coronavirus has the spike protein on it. And everybody knows that the spike protein is where all monoclonal antibodies and all vaccines that produce antibodies are going to be directed. Now, that spike protein contains two separate particles. One is a S1 protein that is responsible for binding to the ACE2 receptor on humans to allow it to attach. And then there's the S2 protein, the second part of it, that allows for the virus to get in. Everything that we do to prevent the virus from getting in is directed at that spike protein. Next slide. So what about these viral new platforms? So they're easy to make. The harmless adenovirus, which really is harmless and has been used in gene therapy to date, not very much with vaccines, is a way of introducing a novel piece of particle. It could be messenger RNA, it could be a piece of DNA into the body, which then the body recognizes is abnormal and produces an antibody to it. And that's the spike protein. And the messenger RNA is just a slightly more direct attempt of doing the same thing, where a little piece of messenger RNA that codes for the spike protein is introduced and people react to it and make antibodies. There is a high incidence of pain, fever, chills. One of the things that no one realized when they were doing double-blind studies is that people know whether they're getting a placebo or not, because the people who get the vaccine all have sore arms, fever, chills, and malaise. And the people who who are not getting the vaccine know, right. There are people very concerned that knowing whether you're getting the placebo or the vaccine will alter behavior and skew the results of tests. Another complication that no one thought of until very recently. Next slide. So what about the finalists? Okay, let me review them quickly and go through a couple of new things about them. So on the right slide is the Moderna vaccine and the Pfizer vaccine. Those are the two messenger RNA vaccines. They're both in final stages. A brief look at the results of the Pfizer vaccine less than 2 weeks ago showed that there was no statistical significance. There weren't enough people in the study to record whether it works or not. This is the vaccine that has the complication of needing ultra cold storage and is only good for 24 hours after it's thawed. This is the one that's technically going to be difficult. The Moderna vaccine is a little bit easier. It's stored in a regular freezer and it's good for about a week after it's thawed out. Now, the viral vector vaccines both of them had a pause. The AstraZeneca one on the top of the slide was paused because of a case of transverse myelitis. It resumed in Europe very quickly, and it resumed in the US about 2 weeks ago, their trials. There's been no statistical significance that anyone has reported with that trial yet. And then finally, there's the Johnson & Johnson one on the bottom of the slide. This is the only vaccine that's going to require one dose. It's a one-dose trial. Again, it's with an adenovirus, very similar to the AstraZeneca trial. And again, these both need storage in the cold, but not ultra storage, or not ultra cold, excuse me. And finally, there's the Norvax vaccine, the Bill Gates vaccine, which is a DNA vaccine. And that too is in phase 3 trials, but not in the United States, and will come a little bit later. Next slide. So this is the new slide, and I don't think people completely realize this about these vaccine trials. Most people think, oh, there's going to be a trial, and at the end of November or December or January, you're going to find out it worked or it didn't work. And it's not that simple, folks. The FDA, when you design a trial, requires you, before you design the trial, to state what is the goal of the trial. And you can't change that goal once the vaccine trial has started. So what are the potential goals and endpoints of a vaccine trial? Well, the first one would be it prevents all infection, and that would be great, and that's what everyone's hoping. But the second endpoint may be, well, it doesn't really prevent infection, but the people who get infected are asymptomatic, and that would be still good, not as good as preventing infection. And then the third endpoint was, well, like a flu vaccine, it doesn't really prevent infection very well, but it prevents people from being admitted to the hospital. And that would be the third endpoint. Now, the fourth endpoint is, well, it doesn't really prevent hospitalization, but you're much less likely to end up in an intensive care unit, which is also true of the flu vaccine. How many times have I told people the benefit of the flu vaccine is not so much to prevent flu, but prevent you from dying from it or being in the hospital? The next endpoint would be, well, again, it prevents you from being on a ventilator. And then the final endpoint would be preventing death and, more importantly, preventing transmission. So all of these are separate endpoints, and these vaccines may not meet all endpoints. They may meet 1, 2, 3, 4, 5 endpoints. And depending upon what those endpoints are going to determine how successful that vaccine is. I mean, let's just say this vaccine is not a great vaccine, but it still prevents transmission. That would be a reasonable endpoint. So keep in mind this, when these data come out, it's not going to be a yes, no. It's going to be a lot in between. Next slide. So to end up the vaccine story, no vaccine has ever produced longer lasting immunity than a wild type infection. That means there's going to be boosters. Reports of reinfection are overrated in my opinion. They are reinfections, but there's only been about 5 to 10 reported to date. It's not a terribly important thing at this point in time. Tune in next year to see if we're still saying the same thing. Safety, 1 in 1,000 serious adverse events with a vaccine given to 100 million people means that 100,000 otherwise healthy people will be harmed. These are not sick people with end-stage cancer where you roll the dice and say, we don't have anything to lose. We have a lot to lose, so we have to be very careful. Efficacy. The FDA is not committing, but they think it'll be around 60%, 50% that they consider adequate to license a vaccine. And that means that it's good, but it's not great. So if only 40% of the population takes a vaccine that's 60% efficacious, we're not out of the woods yet, folks. And we have to be careful because if we screw this up, there will never be trust in a vaccine again. And we already have that problem today. Next slide, please. All right, moving on to the second topic of the night. Everybody in this sophisticated audience knows that there's only 2 types of diagnostic tests that are used to diagnose COVID. One is the PCR. It doesn't distinguish between live and dead viruses. The results can come back the same day or up to 5 days later, depending upon where you send it. And it is used on throat and saliva. It's expensive. The cheapest price I've seen is $25, the charge to Hofstra when Northwell does it. Most people pay closer to $100 on the outside. And then there's the antigen test. You know, these are looking for specific proteins, not the DNA or RNA, depending upon the test. Now, the results come back in less than 1 hour. The cost can be as low as $5. That doesn't include the administrative cost. So from a practical point of view, they're running about $25 to $30. But it is a law of physics that detecting protein as opposed to genetic material are going to be a lot less accurate. Next slide, please. So what are the findings? And I could spend a lot of time talking about this. I've educated myself a lot about this over the weekend, but I can tell you that the Abbott Now test is a rapid test. It is not an antigen test. It is really still a PCR test, but it's a much less accurate test. And in this one study I'm showing you, it was compared to a standard PCR test, in this case, an Abbott PCR test. And what you can see is the overall positivity rate in the Abbott Now test was 35%, and that agreed with, didn't agree in 75% in the PCR test. So Abbott ID Now was associated with a lot lower accuracy compared to a regular PCR test that we do in our laboratories. Next slide. So what about the antigen test? Well, I am very critical because Abbott, and I think due to the imperfection of the FDA, called its antigen test Now test just the same way it called its PCR test Now, which is very confusing. It's confusing to people who do this for a living. I can imagine how confusing it is for people on the floor. They call this the Biax Now as opposed to the ID Now test. Very, very tricky. Now, Abbott predicted that this test had a 95% sensitivity and 97% specificity within 7 days of symptoms. I am going to be publicly state, while this is being recorded, that this is not true at all. These were spike samples in a laboratory. The FDA allowed this to happen, but it's really not accurate. The government has shipped over 150 million of these tests to all states. We're starting to get them in New York. And what's the results? Although they report those results, these data have not been validated, and I show you what the real data looks like in a second. Next slide, please. So before I do that, I want to very briefly summarize that the Abbott now is the one that we're seeing the most. But the BD Veritor test is the one that was in the New York Times the other week because it failed in nursing home patients and they had so many false positives. The Quidel is also being looked at by Northwell and is another antigen test. Quest has one, OraSure, pay attention to that, is going to be a home test that will probably be on the market by January, very similar to the home HIV test and home pregnancy tests. The eBio test is another one, and Roche is the last one that I'm aware of. Next slide. So to finish up, these rapid antigen tests, millions are going to be used, but the Cochrane review, and I don't know how many of you like Cochrane or not, but I think it's a good organization, and they report that the average sensitivity of antigen test is about 56.2%, not even close to 95%. These tests have not been validated in asymptomatic people. All of that data I showed you was testing these tests in people who were sick. So asymptomatic people probably have even a lower accuracy. To date, antigen tests have been found to be much less sensitive than others. They're still going to have a role. We have to do them because they're quick, they're cheap, and you can do them over and over again at site. Let me just tell you that this past week, we started doing tests on Hofstra athletes, the basketball team and the women's and men's team. And within 2 weeks, barely starting the season, we've shut down both teams for 14 days for quarantine because we had positive results. These are the examples of where antigen tests, when you have to do daily or every other day tests on populations, we might be able to use this, particularly when the incidence of the disease is very low in the population. Next slide. I think I'm finished, David. Yep. Thank you so much for the time.
Bruce, thanks for the update. I'm going to hold some of the questions I have until we get to the panel discussion later on, but stay tuned for some, as they said to Donald Trump on 60 Minutes, for some tough questions. So we're going to move to Mark Jarrett, who's going to talk to us about COVID-19 hospital visitation policy. This is a big concern to people, not only consumers, but also people in the hospitals, since I think it's a tough area. You guys have done a great job. A little confusing. Hopefully you can straighten us out.
Yes, Dave, thank you. I will try to clarify it. Please understand that visitation is based on Department of Health rules. So what I'm saying today could be changed by tomorrow. There could be a rule coming out. But really, the basic issue is the balance between compassion and safety. We all know the terrible experience of having people that were in the hospital at the time about to get intubated and having to say goodbye to their families on FaceTime or on their iPad. And that is not really the way we want care to be delivered. On the other hand, both the safety of the visitors as well as the safety of our staff had generated the concept that we must follow what the state is saying and protect everybody, especially when COVID was so widespread initially. What has happened now in recent in the last month or two is the state has eased up the rules. However, we are now seeing hotspots, and it's important to recognize because of those hotspots, we really need to focus on what I call microzones. That is, not widespread the same rule for every hospital or every site. What's going on up in Westchester may not be the same as out in Riverhead with Peconic. So we need to really start getting a little bit surgical in our approach of where we're changing visitation rights. Come to the next slide. So the current rules, with the exceptions I'm going to go into on the next slide, are there are 2 visitors per day with a time limit how long they can spend there, and the hours are set by the hospital. So some hours may say 2 hours for each visitor, some may 4. They may have variation, as I'll mention, based on the hospital and based on the individual situation. All visitors need to be screened at the entrance. They all get their temperatures taken, and they must wear a surgical mask. Now, that tends to be a little problematic at times. A lot of the visitors coming in have these cloth masks. Some are not bad and actually act pretty effectively. Many do not. Some people I've seen walk in with basically a handkerchief tied around their nose and mouth. That is not going to provide any protection. So what we've asked, just to make it easy, all visitors coming in, if they don't have a surgical mask with them, we will give them one. That provides protection not only to them, but again, to our staff, which we must always protect. And their visitation is limited to the patient's room. They can't be sitting out in the hall. They can't be sitting, hanging out someplace. They really need to stay just in the patient's room. Can I have the next slide? And a very important concept is visitation can be tightened at discretion of the site. Again, the rule is general, but we need some flexibility for the individual sites for tightening. So for example, just recently, as you know, there was an uptick in several parts of New York City, including Queens. And actually, Forest Hills Hospital wound up being in one of the hot zones, or what they've called now red zones. Because of that, we decreased the ability of visitation down to 1 visitor per day to decrease the flow of people coming into the hospital. And that makes sense because remember, most people in the hospital are catching the disease from the community, and therefore the visitors are the ones bringing it in. So we really want to decrease the number of visitors. We did not feel it had reached the point that we would say no visitors, but we did decrease the visitation. Can I have the next slide? Now, there are exceptions to this rule. On labor and delivery, you're allowed 1 support person who can stay for the length of your delivery and even into the postpartum period, okay? If it's requested by the mother, they can also have a doula be there, but the doula has to leave after the delivery. In the antepartum time, we can have up to 2 visitors, but we are allowing only visitors over the age of 18. And this again makes sense since we know that young children may be asymptomatic carriers, and we want to decrease the number of people coming in who might have the disease and have active infection and spread it around the hospital. All right. Now, another exception is a one support person anytime if it's essential to care. This is especially true with developmentally disabled patients, with other problems as well. It may even be with dementia. We will allow 1 support person in at any time if that's not just in the time limits. If the patient has COVID, is actually ill with COVID at the present time, we allow visitation if it's in a single room. If the patient's in a double room, obviously with another COVID patient, we are not allowing it this time. At the present time, thankfully, our COVID population in the hospitals is so low, we can't keep them all in single rooms. And finally, in pediatrics, we allow 1 parent or a guardian or a grandparent to be in at a time, right? That doesn't mean that both parents can't visit, but again, 1 at a time to decrease the flow. Next slide. Same-day surgery, which may occur at a hospital as well as in a regular ambulatory thing, we can allow a companion to come in and accompany the patient through the initial intake process. They may be able to answer questions, etc. They can rejoin for the discharge process. We have liberalized this because it was recognized that it was really important for somebody other than the patient who may have received even sedatives to understand what the discharge instructions are. During the recovery period, such as in the PACU, except for pediatrics, childbirth, as I mentioned before, and again, the exceptions such as developmentally disabled, we do not allow visitors, but in those 2 cases, we do allow visitors, just as we do for inpatients. And finally, a very important concept, at end of life, we will make exceptions, and this is where really compassion comes in. We've had it where families have flown in from other parts of the country, been appropriately screened, and have allowed them into the hospital to say goodbye to their loved ones. We have to make sense out of this. We just can't do things that just following the rules without having some flexibility again. Next slide. And I think that's it. And I hope you understand it. And if there are any updates to the visitation policy, we will certainly get it out right away.
Also, Mark, we'll have some questions for you on the panel. But before we get there, one of the concerns comes up is are we limiting the total number of people who go into a building at one time? Sometimes we see lines outside the hospitals. Is that because, too many people are coming at the same time? Should we be staggering the hours so that we can accommodate a certain capacity without overwhelming people and staff at certain times of the day?
Yeah, I think that is true. The hospitals really need to start staggering it. They may say certain areas are between, 8 and 10 or 2 and 4, and another place is 10 and 12. It's difficult. Sometimes people work and therefore their visitation time is, somewhat restricted, but it is important to keep down the line. Also recognize the line represents people coming in during the day to get tests or even procedures in the hospital setting. So that sometimes also increases the line. But clearly we do, even with social distancing, we don't want crowding in the lobby.
Got it. Thank you. Dr. Carney, one of the most contentious areas, I'm sure, as everybody is aware, is as the impact this has had on our skilled nursing and other congregate living facilities. Tell us about the rationale, what's the standard, and what can we expect moving forward?
Sure, my pleasure. Thanks for having me. And I'm sure all of us and everybody out there has been seeing the news. And this is a recent case that was presented by NBC News of a daughter saying that her father fell victim to the pandemic, but it wasn't COVID-19 that killed him. It is this concept of failure to thrive because of the stark visitation rules that the Department of Health and CDC have put out to save people from the spread of the illness have led to an unintended consequence of isolation that we're hearing a lot about. Next slide. The news has captured this. We've seen family members take laundry jobs at nursing homes to see their loved ones. Forbes reported this epidemic of loneliness in nursing homes. A husband wants to become an essential caregiver, advocating for assisted living. All in all, many different news media sources, whether it be the prominent newspapers, the business newspapers, local, we're seeing this across the country. Isolation is now the outcome of our lack of visitation in skilled nursing facilities. Next slide. We've seen images as well. And people are being creative on how to visit at facilities. They're doing drive-bys. They're going through windows, seeing and bringing loved ones up to the window. And New York is facing this dilemma because we have the highest population of nursing home residents than any other state in the country. And this doesn't even include assisted livings or group homes, which are also congregate living and pose the same risks and follow the guidance of the New York State Department of Health and CDC guidance to mitigate the spread of illness. Next slide. So this has been reported in the media, the deaths, and this is the problem and why we've had a decreased or lack of visitation early on, especially in the downstate region during the outbreak that we all lived in the epicenter of it. Deaths of nursing home residents, which started out actually in Washington State. Next slide. We've learned a lot about. And for those of you who may have watched 60 Minutes last night on November 1st, it presented the case, the first outbreak that identified COVID-19 in a skilled nursing facility at the Kirkland Care Center. And to their credit, they published their findings in New England Journal of Medicine and really showed how COVID spread between facilities by healthcare workers. And it was soon after that we saw that it was likely asymptomatic spread by healthcare workers. And I'll explain the history as we go forth. But this depiction just shows how one healthcare worker worked at facility A and then facility B, and 2 patients were transferred between facilities. And that's how the outbreak in nursing homes has spread through workers. Next slide. We learned how the spread between individuals. This graph or this graphic shows are the number of skilled nursing facilities in our health system. We have from Westchester out to Riverhead, 295 skilled nursing facilities in our region, an enormous number of skilled nursing facilities. And again, this does not include assisted livings or group homes. Next slide. And in our health system, how we get individuals to nursing home is largely through our discharge to subacute rehab. And there's two different types of rehab. There's subacute rehab, which is largely in skilled nursing facilities. And then there's acute inpatient rehab, which is largely in hospital settings. And if you see, being discharged from a hospital after an illness, while acute rehab is about 2,800 discharges from our health system, subacute has over 25,000 discharges accepted. And so we are discharging individuals into skilled nursing facilities across our health system in 2019, over 2,500 discharges in 1 year. Next slide. So as we are discharging individuals to skilled nursing facilities for subacute rehab, and then perhaps they're going there for long-term care, why is it that congregate living facilities have such high risk for spread? Well, these facilities have been developed as architecturally as an infrastructure focused on socialization. They have cohabitation, 2 people per room, sometimes more. There are units surrounding a nursing station so that it makes the ease of care as efficient as possible. It's built on socialization, communal dining, social areas and activities. It is not a hospital. There's no negative pressure rooms that we use in hospitals to prevent spread of the virus through the air. And there's largely not oxygenation. It's limited medical services, so it's a high-touch medical care that's provided. The staffing ratios, there's nurses that provide care and certified nurses aides that provide care, and it's largely 1 to 12, 1 to 10, even higher ratios, and it differs across facilities. So 1 nurse or 1 CNA has much larger number of patients or residents that they care for than in a hospital setting. Medical care, the physicians that go to a hospital also go to their office and sometimes go to multiple skilled nursing facilities. So staffing of nurses, aides, physicians are going to multiple facilities, as the New England Journal article showed. And then the resident or the patient characteristics, these individuals need personal care. You cannot socially isolate. And if they have dementia, maybe they're wandering, they can't wear masks, they don't know how to follow guidance. Individuals may have wound care, complex medical needs. And largely this is an older adult population who have what we call immunosenescence, an aging of the immune system. Their ability to fight off infections is harder. And then there's the characteristics of the virus itself. It's very infectious. And early on, the R0, or how it infects, 1 infection was reported early on to be able to infect over 5 people, while the flu is much less than that. And then the concept of asymptomatic spread. Somebody without any symptoms can spread this. And this is what we learned during the last few months. Next slide. So over the spring from March, early on, there was no visitation at skilled nursing facilities. And again, assisted living group homes followed this guidance. You couldn't be discharged to a skilled nursing facility unless you had 2 negative tests. And they had guidance provided to employees, what personal protective equipment to wear, and infection control guidance. And then hospitals were overwhelmed. There was community spread. Skilled nursing facilities had cases of COVID that were erupting in their facilities. So they identified COVID units, and it was announced that COVID positive cases could be admitted to facilities. Then May 11th, they stopped that. They started testing of employees to minimize the spread. Still, visitation was not an issue, but on July 10th, visitation opened up. but only in outdoor areas if there was not a case in the last 28 days. But then recently in September, they shortened that time period. If a facility did not have a case in 14 days, they could have limited visitation. Largely outdoors with ventilation is preferred, but they do allow some visitation inside, but it has to be a max of 10% of their number of residents that they have. So just what you were explaining, Dr. Battinelli, that they do have a limit of how many visitors can come in, and that's being used at skilled nursing facilities right now. Exceptions are made for end of life and for compassionate reasons. However, really visitation is still a tremendous limit. Next slide. So there's implications of this policy, of this limited visitation for this vulnerable population. Yes, it mitigates the spread, but it also promotes prolonged hospitalization. We cannot go to a skilled nursing facility unless you're testing negative. And that prolonged hospitalization makes that somebody comes into a facility perhaps more confused, more isolated and depressed, lonely. They may have suffered falls. And then with being in a state of decline, they have higher care needs when they go to facility. And visitation needs is important because often family or loved ones are not just visiting for social reasons, but also for care purposes. And that becomes an ethical dilemma. And of course, this is a chapter of a person's life, which is largely an end of life chapter, not an end of life moment, but a chapter. And we want to try to help keep this chapter as high a quality of life as possible. So I think moving forward, what we need to advocate for in terms of visitation in skilled nursing facilities or congregate living is to equate visitation with caregiving. And we need a path for family members and or their caregivers to be more equated like employees. Let them get tested, let them have the PPE, and let them be involved in the day-to-day care of their loved ones at a skilled nursing facility. Next slide. So thank you very much, and I'm happy to take any questions.
All right, so let's get together for a panel discussion. Dr. Farber, I told you I'd start with the tough question. So tell us, when can we expect a vaccine? And I know that you're working with the state on trying to figure out how, in fact, we would actually distribute a vaccine across the state. What do you think, and what should we expect?
It'll either be the Moderna or the Pfizer vaccine that you will see first, one or the other. They'll be very close to one another, and I predict you'll see some early results in mid-December, and vaccines will start being distributed sometime in the winter.
So the next easy question, since it's the one they ask me in the media all the time, are you first in line or last in line?
Honestly, and I tell people, I want a vaccine, but in all fairness, I want 2 months of follow-ups. I don't think that anything less than that is adequate to look for toxicity. So as much as I want to be the poster child for you and Northwell and getting the first vaccine, I really think that we have to be careful. We got to get this right and not too fast. And so I'm not going to answer that quite yet. I mean, we just haven't seen the data.
But I think I've heard you say in the past, though, that when you've seen the data and when you're satisfied, you believe that vaccination is the way to go.
100%. And I will be, right online to get it. Absolutely.
Right behind you. Okay. Let me ask you the question about the rapid testing, because it would seem to me that with the laboratory industry and everyone there and the length of time that this pandemic will continue to go on as we've been through before, that rapid testing, when in fact it's better than it currently is, really is the key, along with the masking, social distancing, and careful hand hygiene, et cetera, to getting through the next year and a half or two, especially as we try to open things up, get people in and out of nursing homes, get people into areas that we need to open up. Do you agree with that?
I do. I mean, unfortunately, it's always bad news, and I wish I had good news. And the one piece of good news I would say is there's only been 5 cases of influenza that have been diagnosed in the United States to date in this season, which is remarkable. really remarkable. So it doesn't look like there's going to be two pandemics or two epidemics occurring at the same time. That's the good news. But yeah, David, I mean, realistically, vaccine or not, we're going to be wearing masks until at least a year from today. And that would be great. I think it'll be longer. And, you know, lying about it is not going to help.
Mark, on visitation, as you said, you know, the state could turn around and change this all tomorrow. What about for our healthcare workers? I know that there's lots of concerns as we maintain our workforce and we have to move around, and the quarantine rationale for people coming back, and how do we combine that with testing to keep, you know, our essential workers front and center?
Well, you know, one thing we've always done right from the beginning, and we were very proactive in the beginning, is making sure that our workforce is protected. So even early on, when it was obvious you would need an N95 respirator in a COVID unit or in the emergency room, we had decided that all of our employees should be wearing at least surgical masks walking around the hospital. And I think that was a good thing. I think the initial study that came out that looked at antibodies in our staff showed that they actually had at worst the same penetration of antibodies as the community, in some cases actually even less. I think we have to continue it that way. I think the quarantine on travel that was just changed makes sense. Keeping many of these people away for 14 days really did not add much. I think this compromise now of testing after 4 days of coming back from travel, and if you're asymptomatic and the test comes back negative, which will take at least another 24, 48 hours, so you're really talking about day 6 or 7, I think at that point it's safe to bring people back, and it'll be much easier to maintain the workforce. It's not only that we want to keep our workforce safe, we have to keep it robust. If we have too many people out, left are going to burn out. And when you get tired, that's when you make mistakes and might get exposures. So it's really important that we balance everything in this regard.
Thanks. So Dr. Carney, on the assisted living, nursing homes, and other places, I think what I heard in your message is we have to obviously maintain good, safe practices, but we have to, as Mark has sort of talked about with the visitation, we have to be compassionate. We have to figure out mechanisms that can allow visitation. Otherwise, particularly in that population, particularly at that time of their life, maybe we are doing more harm than good.
Yes, absolutely. This is a vulnerable population that has great need. We have to protect them from ourselves, but we have to help them. It's complex. I don't know that we have an answer, but I think by providing the protection, prioritizing infection control, personal protective equipment, and testing, we can do a much better job. And the visitors need to become caregivers or equated to employees.
Now, since we've had some of the strict rules put in place and relaxed some of them even as early as May, my understanding is we've done pretty well in the nursing homes in terms of the numbers of patients that have become infected, and certainly outbreaks.
We've done a wonderful job. It's been incredible. The strict control, the testing of employees, and the provision of protective equipment, and the guidance in terms of infection control at the level at the skilled nursing facilities has been phenomenal turnaround. It came through the community spread, and we were looking at it in different ways. We've learned so much over these last few months, and I think the stepwise approach of opening and providing guidance has been very smart, and it's been working.
And Mark, I know you and Bruce are also working with the state trying to make the determination on if, in fact, there is a safe and effective vaccine, what will be the prioritization and who will receive the vaccine earlier. I assume healthcare workers are on the list, but I assume high-risk populations and nursing homes are probably also on the list.
Yeah, they're all on the list, and actually, you know, there will be a limited supply in the beginning. So, you know, if you think of the first phase, there'll be a phase 1A and 1B. And in the past, one always thought that the healthcare workers would be the first on the line. But now it is starting to shift to the recognition that, though, you know, based on what Bruce had said about, you know, trying to get to those endpoints, those most vulnerable, those in long-term care facilities, as well as the vulnerable population in general, probably should get it first. This will include some of our, some of the areas where they had the hardest impacts, such as the African American community, the Hispanic community. The mortality rates were definitely higher, and we have to figure out a way to make the vaccine distribution not only medically safe but equitable to really reach the populations that are most vulnerable.
Yeah, this will be an incredible task moving forward. So I congratulate you guys for helping, and our fingers are crossed, and hopefully this goes well. Since supposedly we're supposed to have a vaccine any day now. So let me conclude with a couple of more recommendations on a book. If I can go to the next slide. This is on the leadership side. So this is Team of Rivals. The Doris Kearns Goodwin book, Pulitzer Prize winning author on the political genius of Abraham Lincoln. This is a picture of he and his cabinet. And what Lincoln said at the time was, and arguably no more contentious period in our country, was that we need the strongest men of the party in the cabinet, now men and women. We needed to hold our people together. He said, I had looked the party over and concluded that these were the very strongest men. Then I had no right to deprive the country of their services. And it turned out that these individuals of his cabinet, and there's Salmon Chase, who was the Ohio governor at the time. He made the Secretary of the Treasury. William Seward, who was a New York State Senator, he made Secretary of State. And Edward Bates, who was a Missouri elder statesman, he made the U.S. Attorney General. But these were the three other people who, in fact, were in the race in 1860 for the presidency of the United States. And it was as much mudslinging back then as we see today. But he, through his political genius, brought this group together. And he decided that, he needed to keep this group close, not only to have diversity of opinion, but also to understand what the contentious issues were, rather than isolate himself from the issues. So next slide. I think this is a picture from the front cover of the book. Another long read, so I don't. Sorry about the two reads. I think we're going to total about 1,500 pages if you're going to look at these two books. But this one, if you want to look at something on pure leadership, is really genius, and then was made into the movie that you saw in the last couple of years. So. Again, I want to thank our panelists. I want to ask for some feedback so that we know what we should be talking about in the weeks to come. I think it's probably going to be pretty obvious. We're looking at a lot of issues going on right now. And last but not least, the real work that goes on to produce this is on our team behind the scenes, and a very special thanks to them. And until 2 weeks from now, be well, be safe, and good luck.